Well, kia ora koutou katoa. Welcome back to the Ministry of Health. Pleased to report again today there are no new positive cases of COVID-19 in the community, and we have 6 new positive cases in managed isolation to report. All of those were identified at day 01 testing on arrival into the country. We have got 2 people from managed isolation facilities who are currently in Auckland hospitals. The second of these is one of our new positive cases we're reporting today and was taken to hospital last night. We still don't have confirmation as to whether that's COVID-19 related or related to another condition. I'm advised all infection prevention and control IPC protocols were and are being followed, of course, and both patients are stable. And hospital staff are now well used to providing care for COVID cases, and the hospital is safe for both staff, patients and anyone who needs to visit or attend outpatient appointments. On the testing front, we had another big day of testing yesterday with 14,671 tests processed, and of those 7,853 were across the Auckland region. That takes our 7-day rolling average to 9,721. There are 11 community-based testing centres open in Auckland today again, and a reminder that people can also get tested at their GP or at an urgent care centre. There will be pop-up testing today at Ngā Whare Wātea Marae in Mangere, and the Auckland DHBs are working closely with Tūruki Healthcare there. Today our contact tracers are focusing on further follow-up of close contacts, all of whom have been tested already once and returned negative, and close plus contacts related to the MIT and City Fitness locations of interest. Since Monday, 45 home visits have been undertaken by welfare providers in Auckland in partnership with the local public health service, and I should say that in all 45 of those visits, the people whose homes they visited and who were expected to be isolating were isolating. Of the 185 attendees at City Fitness in Hunters Plaza on the 26th of February, these are all identified as casual plus contacts. 156 of them have returned a negative test, and there are 29 people who are due for testing, and we are following up those results today. Likewise at MIT, there are 44 casual plus contacts from the 22nd and 25th of February. 2 have returned negative day 5 tests, and all have been successfully contacted. The other 2 who haven't yet returned a test result, that has been followed up. On the Kmart front, of the 1,882 people who were at that exposure event, that has visited the Kmart on the 2 evenings where one of the cases was working, 43 have not yet returned a test result. 42 of these have actually we've been in touch with, and they are complying with isolation requirements and are being actively supported to have a test. If they can't get out and about to do that, then we can send a mobile testing centre there. And finally, on Papatoetoe High School, in terms of contact tracing, there are 11 high school students we don't have a second test result on yet. 8 of those were visited yesterday. They are from 6 separate households, and mobile testing vans are taking tests from them today. 2 of the remaining students have refused the test, and they are being managed with isolation plans by Auckland public health officials. And there is 1 outstanding student that contact tracers are working actively to find, but I should say that student is known of because they also have previously returned a negative test between the 15th and 19th of February. On the wastewater testing front, further results from ESR testing has been returned, and samples taken on Monday at 3 Auckland sites, which include wastewater from Papatoetoe, have come back negative for the virus, and samples from Christchurch and Rotorua were also negative. We'll report further testing results as we get them. On saliva testing, which I know there is keen ongoing interest in, we are continuing to trial this in our quarantine facilities and investigating how it can add value to our current surveillance testing regime in New Zealand. I just saw yesterday actually a report from the Australian Public Health Laboratory Network with their conclusions around the use of saliva testing, and like us, their view is that in a very low incidence situation like we have in both Australia and New Zealand, that the nasopharyngeal PCR-based test is still the one to use, but that saliva testing can play a role in surveillance testing. In other words, the asymptomatic testing we are doing of our border workforce in particular. And at this stage, that's our view as well. We are doing the trial in our quarantine facilities, but also working with 2 or 3 private providers who have established saliva testing and now validated that with one of them, and most likely we're planning to see if we go into an arrangement with one of them to look at using this as a complementary testing method in our border workforce. Healthline continues to be busy. We'll publish the numbers on our statement. The longest wait time yesterday, though, I can say, was 11 minutes. Finally, on our vaccine program, which continues to roll out, including in Tamaki Makaurau, despite Alert Level 3, we have got more than 800 vaccinators now around the country who have completed the specific training module for the Covid-19 vaccine, that is to use the Pfizer-BioNTech vaccine. So that is going well. To date, there are 13 district health boards now rolling out immunisation programs across the motu, including all that have a port or an airport, of course, to capture that border workforce. And we're making our way through the MIQ staff. And by midnight last night, we were over 2/3 the way through that border workforce, having had their first vaccination. So good progress there. I'm happy to take questions.
With no new cases in the community again today, is Auckland in Alert Level 3 still justified?
At this point in time, yes, it is. And the main reason being there that the reason we gave advice around using Alert Level 3 in Auckland was because we had, in case N, an active case who had been in the community for nearly a week, and the last significant exposure event was on that Friday afternoon at the gym. And we're not yet a week on from that. Yes, we have found many of the people who were at that gym. They're all Casual Plus contacts, and so far the testing is promising, but there is still some who we need to get test results back on. And of course, we need them to remain isolated until we get those negative test results.
So now is not the time, really, for Cabinet to be reassessing whether we jump out of those alert levels earlier?
No, not today, and they are planning to meet tomorrow afternoon with our advice and make a decision about whether Alert Level 3 continues beyond when the current one is due to expire, which is late on Saturday evening.
What are the key pieces of information that will inform your advice to Cabinet?
Look, so there's a set of criteria that we always report on, and some of those are fairly routine around lab capacity, and we've got very good capacity in our labs, around 25,000 tests we can process each day. They're around contact tracing capacity, so we always provide advice around those two things. But the key things that we're looking for is, as has been noted, not just the fact that we haven't got cases from the close and Casual Plus contacts in these potential exposure events, but also, and this is a really important part of our advice, is the wide testing that's happening both in Auckland and outside that will increasingly provide assurance that we haven't got onward transmission into the community. So those high rates of testing over the last few days have been incredibly helpful, and we want to maintain a pretty high rate of testing over coming days too.
And so is it possible that we do record new community cases tomorrow but still are ready to move alert levels?
It would depend where those community cases were from, and also, of course, now we can rapidly get the whole genome sequencing, being able to both epidemiologically and genomically link them back to our existing cases. Remembering, though, that all our 15 cases we have got are within 4 families. All those families are contained, including the most recent one in the Auckland quarantine facility, and really we're just going back to see that before they were moved there, that just to confirm that there was no onward transmission before
so
that.
If you had those links, then potentially we could still move alert levels?
Yes, it's the nature of any cases really that come up, but I think increasingly with our negative test results in Auckland and outside of Auckland, because the key reason for putting the rest of the country outside Auckland into Alert Level 2 was because there had been a lot of travel over that period of week, clearly a lot of people travelling between Auckland and the rest of the country, and we just needed to be sure that there hadn't been seeding of this outbreak outside of Auckland.
Case M, who went on the walk with another Christian level 3, they were originally thought to, when they tested positive, to few days prior because they were asymptomatic when they tested positive. Have their contacts going back further now been traced because we know that they were likely to be infected case a week before we first thought they were infectious?
Yes, so yes, we have gone back, or the contact traces have gone back, and just there weren't any other exposure events for case N. The main one was in the workplace, and so all the workplace colleagues were close contacts, and they were quite quickly isolated, and they've all tested negative.
Is it confirmed that walk was where exposure happened, occurred?
It fits, very much fits with the timeframes that the person who would have infected case N was infectious, and so there's, in terms of the timing, the epidemiological link, and the genomic sequencing. Yes, it's a.
Can you talk more about the arrangement you're coming to with the saliva, the company with saliva testing?
Yeah.
What's the company? How far are you going to go now? What's the framework there?
Yeah. So what I can tell you is we had already been looking over the last 3 weeks at. There is RACO is one of the companies that we know is willing, ready and eager to go, but they're not the only one. So what we're planning here is, alongside our trial of voluntary use of this inside our quarantine facilities at the moment, is to look at, probably we will go out to the market and with a request for proposal process to see if there is a company who's prepared to provide complementary saliva testing as part of our border workforce testing. And the evidence out of Australia, or actually from the RACO test from the University of Illinois, I think it is, where they used it, is that probably twice a week it doesn't need to be daily, but probably twice a week, complementary to the ongoing weekly or fortnightly nasopharyngeal swabbing. So early days, but the next step is likely to be we would use an RFP process.
Right, yeah, because the way you said before, I thought you were in arrangement with a specific company already, or that you were looking at one company, but you're putting out the tender offer.
That's right. There's one company that's been very active in promoting its product and so on, and that's but there's no, and we have been actively engaging with that company, but there's no commercial arrangement at all between us.
Why move towards the private providers as well, when you're running this trial of your own test?
The main reason is that actually the saliva testing still uses the PCR laboratory process, so it's still a PCR test, and so our current labs are, there's quite a lot of work that they have on with the current testing right across the country, as well as the surveillance testing. So the idea would be, if we can get to an arrangement with a private provider, remembering that a good proportion, probably 40% of our nasopharyngeal swabs have been processed right from the start through private laboratories. So we've had private laboratories as part of this right from the start. But it would be so that we don't disrupt or compromise any of our current testing capacity, especially when we need to use that in a situation like now, where we need to have that surge capacity online.
On the trials for the nasal swabs, do you have any sort of numbers or metrics around how many people would want to try that on before you would sort of deem successful?
So you mean the saliva testing?
Yeah.
Yeah. So I guess we've now validated the science. So what the RACO in particular had put forward is the accuracy of the test compared with using a nasopharyngeal swab. I guess what the trial is about is really about acceptability and the practicalities of getting the samples, getting them to the labs, alongside all the existing IPC and testing protocols in our facilities. So that's just giving us some useful information about what's the simplest process to establish to be able to then incorporate saliva testing as part of the ongoing surveillance testing.
Time frame for those trials, or when you
well, they're ongoing at the moment, and don't have a time frame for when that RFP might be going. The request for proposal might be going out, but it's actively underway. Yes.
What would you like to see over the next 24 hours in terms of being confident moving down the levels at the weekend, and what at the moment are your biggest areas of concern?
So I think what we will be looking for over the next 24 to 48 hours, right through up till the final decision, is continuing that our close contacts remain in isolation, and we've got that at the moment, and the first tests were all negative. That's good. I'd like to see the tail of those casual plus contacts, particularly from the gym visit, which is the last of the visit of the sort of big exposure events last Friday afternoon. We'd like to see those test results coming in, and we're actively chasing those. And then, of course, just not seeing any other cases pop up from the testing across the community, because we're pretty confident now we've got a sharp perimeter around this particular outbreak. All those things will give us confidence that there hasn't been onward transmission.
Yeah, it sounds like there are some individuals who find it hard to contact or who are refusing tests at the moment. Is that concerning, or is it?
No, it's not really concerning. I guess, just to come back to our high school, where we had extraordinarily high rates of testing amongst the students and staff, not just the first time round, but also for that follow-up test. And I mean, this has been the case right from the start, that the vast majority of people who understand what's required do voluntarily get the test done, and of course isolate. And again, right from the start, this is not an enforcement-based approach, and I think we saw this morning that police released the data that I think they've done 1,000 prosecutions since March last year, and my understanding is most of those are for overt, repeated breaches of alert level expectations. But the vast majority of people are doing what's asked of them, and I understand all the data around traffic volumes and so on in Auckland is the same this time as it was in August in the Alert Level 3 that was in August as well. So people know what's expected and they do it, and that's how we've been successful so far.
The vaccination program, there's been some push for the South Auckland community to be prioritised for vaccines. Is that something that you would like to see happen sooner?
What I can say is it's something we're already thinking about, and one of the reasons here is if we think about our border workforce, which is the majority of them are based in South Auckland, and also the fact that the last 2 outbreaks we've had in the community have been in South Auckland, we're putting a layer of protection by vaccinating that border workforce and their whānau, and then I think it makes sense that very early on when we start to roll out further, the next layer of protection out would be to not just protect that community, but we would be protecting the wider country by vaccinating that community. So I've asked the team to start doing some thinking about how we would, when we start that wider rollout, go first into the South Auckland community, absolutely.
With those gym tests that you are waiting for, given the significance of those test results, is it a bit frustrating that they are taking a bit of time to come back?
Not frustrating at all. I mean, it's. I think there's been a lot of publicity. People know what the requirement is. All these people have been identified and contacted. Sometimes it's just a matter of doing a match from when the test was taken to be able to match it in the laboratory database, so we're confident we've got a negative test result on people. Sometimes, just to get those last few people, we do have to send mobile units out to test them, but I'm confident we will be able to get there.
Would you categorise those test results as a priority?
Yeah, the priority is for us is to make sure we have tied up all the loose ends from the college, from the testing of other casual plus contacts, for example, in the earlier Kmart exposure, and in particular from MIT and the gym last week.
How effective has the wastewater testing been? Yeah. For instance, were they able to pick up these papatoetoe?
Didn't pick up these papatoetoe ones, so we had a bit of a discussion about this, and I just got an update before I came down. So generally speaking, the wastewater testing will detect about, if there's 1 case per 10,000 people, about that level. So if you think about it in South Auckland, if there's 100 cases, it'll absolutely pick it up. If it's 10, most likely, but under 10, it's less accurate, but about 1 in 10,000. But what we do know is that we've been doing testing of the pipe that drains out from the area that the Jet Park Hotel is in, where we have our confirmed cases, and we routinely pick up positive wastewater test results there. So we know it works. That's our benchmark. But none of our results in papatoetoe over the last 2.5 weeks have shown that there have been enough cases to register a positive result there. I'll just come in.
Is that problematic then, I guess, moving forward? Because if we continue over time to have these sorts of size clusters, and this is kind of what the future looks like, in effect, does wastewater testing kind of become a little bit redundant in that?
Well, talking to our Australian counterparts, where they use it quite extensively, and you might have seen in the last Melbourne little scare they had, they found positive results from different parts of the community around Melbourne, which is where they then directed their testing efforts. So it's complementary. The way they describe it provides another level of assurance. In other words, if we're getting tens of thousands of negative PCR test results from testing across the community, and our wastewater testing is negative, that's another level of assurance that we haven't got community transmission out there.
But you can't actually rely on a negative result, because a negative result won't necessarily pick up a small amount. So
No.
you wouldn't be using that as a factor necessarily anyway, would you?
A factor in advising.
There is actually community outbreak somewhere. You can't rely on that if the number's small.
If the number is small, but again, if the number's small, then that gives and we've got negative testing of the wastewater and negative tests from all the community testing, it helps us triangulate that we're not missing something. In other words, there's not a chain of transmission out there that might have half a dozen, 10, 20 people that we would pick up through the wastewater testing.
On the communications to high school students, have you identified anything that could be done better or differently in that?
Not yet, but we will do that as part of it. We always go and do a formal sort of review with the Public Health Unit, ourselves, our Contact Tracing Centre and our all of government colleagues, so we go right back through and do that in a more systematic way. So clearly that's something that's come up and that we would be looking at. We've had different views expressed on that, but what I would go back to and say that the college community, I think, responded fantastically, and I think it wasn't just the letters, but the communication that went out from the principal was clearly very, very good in helping provide the guidance and the expectation on that community. So we'll have a look at that, and I think there was a key learning there as well, that where you've got really good, visible, consistent leadership, like we had it from the college, that is hugely helpful. It's, again, complementary to any messages we might put out publicly or any specific letters that the community might get.
And just on test refusals, do you have sort of any insight into why they're being refused?
No, I don't. The Prime Minister asked me that very question. But look, I think we see this as well in managed isolation. It may be just a belief system. It may be, there is a small number of people who subscribe to a belief that COVID-19 doesn't actually exist. I know that the vast majority of people don't subscribe to that. Or it may just be they really, really do not want to have a test. But then they are managed, and they're isolated and made sure that there's no risk if they did have COVID-19. And clearly, if they became symptomatic, then that would be a different situation. I think Mark and then...
Do those students who are refusing a test, did they get a test previously during that first round after February 14th?
I think the two that are outstanding have not had a test at all, all the way through.
We just got a story on a Malaysian MP who was visiting New Zealand over the summer. It's unclear how he got through, how he was permitted into the country, or whether he was in the managed isolation system. Do you know anything about this case, and were you ever asked to provide health advice for any sort of exemption to the MIQ system for this case?
Sorry, I don't know anything about it. I'd have to go and find out the details on that one.
On the 23rd of February, when you announced case I was a case, you said no one else in the household had symptoms. Yesterday it said another sibling had symptoms on the 19th. Why has that information suddenly changed?
Whenever we do a stand-up or put information out or communication out, we provide the information that we have at that time. And we always find that changes as further discussions are held with the families and family members. And in particular, with really good questioning about the sorts of symptoms people might have had that they might not necessarily have ascribed to COVID-19. So the information does change, and our commitment is to make sure we're providing the current information in a timely way.
The day after, on the 24th, you spoke about more uncommon symptoms linked to the UK variant of aches and pains. Do you think it would have been useful to talk about those symptoms earlier on in our pandemic?
Well, I mean, this is an interesting thing. We're talking about this just this morning, where some of the things that we see here in New Zealand, you haven't seen overseas, because if you reflect, say, of where this variant was first identified in the UK, in the middle of winter, in a very heavily populated part of the United Kingdom, these things may not have been evident, but the variant just became more obvious, and so they did the work and found, look, this could be more transmissible. Now, the question of whether it's the variant that's more transmissible, how much of it was the fact that it was the middle of winter, whereas we're in a very different situation. And so what we observe is what Dr. Ian Town, my Chief Science Advisor, calls about things that are right on the periphery of the epidemic. So we might observe things that in another situation where you've got widespread infection just wouldn't rise to the top. And I think this is something about the symptom cluster here, and also because these have been younger people being affected here than we've had in the past. We may be seeing symptoms presenting that because they're healthy young people that we haven't previously seen. Kia ora.
Are you confident that there's enough information out there to build confidence among whānau to take up the vaccine?
I'm confident we've made a really good start, but I also know we've got to just be absolutely meticulous in getting our advice out and information out through a range of channels, and having people who whānau, hapu iwi, actually trust. So people they trust, pointing them to the information, the right information. So that's been a focus right from the start. I think we've made a good start, but we're in the long game here, so we've got to keep the effort.
Do you have a date on when that information will start to trickle down to people, like especially kaumātua koe in rural areas?
Look, I think it's already out there, but it's now we haven't gone live with the very big campaign yet, partly because at the moment our vaccination program is very focused on those border workforces. So our information and our campaigns were focused on those workforces and their whānau. But there has been engagement already with regular engagement with iwi leaders and other Māori leaders, just to make sure that the initial information is there, and of course the information on our website, which has already been translated into Māori and other languages.
And so just following on from that, just to clarify, so a couple of weeks ago it was indicated that sort of the first stage of this public information campaign will launch mid-February, the second stage will launch in April. Is that sort of border workforce campaign, is that the first stage, and the big TV ads and everything, that's April?
So the decision was taken because of the outbreak. I did follow this one up because of the outbreak, and also because we're not really starting we won't be starting the wider public campaign, the wider public vaccination program until the second half of the year, was just to hold off on the launching the big public campaign, but that will be at any time.
So the plans sort of changed a little bit because of the...
Yes, because the outbreak, and that became a focus, but it didn't disrupt or hold up the start and the ongoing rollout of the vaccine and among the border workforce.
And Brian Tamaki's now is spotted in the South Island. As our health boss, what do you make of that?
Oh, he does get around, doesn't he? Yeah. Goodness.
Is that putting people at risk, though, the fact that he was in Auckland, then sort of came down the North Island, now he's in the South Island, who knows?
Well, there was a lot of travel from people out of Auckland to the rest of the country, and that's why we, I'm just getting my time reminder there, that's why we are using alert level 2 in the rest of the country. But I think, whether it's the Tamakis or anyone out of Auckland, the request of them has been clear that actually they should be minimising their interaction with large groups of people. And in fact, there should not be large gatherings anywhere in the country, because we're in alert level 2 everywhere outside of Auckland. Final couple of questions.
Hannah Tamaki has stated on social media that she will choose not to receive the COVID-19 vaccine. How damaging is this, or dangerous is this, when communication and marketing is about to come out from the Ministry of Health on vaccine rollout?
Look, I think there are people, and here's someone who have clearly stated their intention not to get the vaccine. They may change their mind, but there are also many, many New Zealanders, and I'm one of them, who have clearly stated their intention to get the vaccine, and we're seeing already a marvellous response from our border workforce, who are protecting not just themselves but the rest of us. And look, I'm confident we've got a really powerful narrative here, and that New Zealanders will, as they have to date as part of our response to COVID-19, they will take up the opportunity and make the decision for themselves.
And just one more, sorry. Have you established who provided the health information to the United Against COVID-19 staff members, and whether that information they sent out
I haven't established that. And my understanding is they were responding to a Facebook post, but I don't know the detail of where they got that information from. But what I would say, again, and this goes to your earlier question, is the information does change over time. And so they may have been making a post based on the information we had at that time. Down the back.
Wouldn't it make sense to start an information campaign as soon as possible? You can see that there are people that don't actually believe COVID-19 exists. So, this is a long game, don't you need to
It is a long game, and I would like to distinguish between this sort of very high-profile public information campaign and the work that's already started. So I've been on a Zoom whānau with over 400 Pacific community leaders, church and other leaders last week. I've done one this week with the Office of Ethnic Affairs, about 150 leaders. Tonight I'm doing a Facebook Live with Minister Henare to reach out into the Māori community. So that's just one example of a number of things that are already underway to get the information out there. And that's a deliberate part of an ongoing communications effort, but it's just the wider public information campaign that hasn't yet gone live, but obviously there's a lot of information already available.
Why haven't we received an application for either Novavax vaccine yet? I presume that means MedSafe should come receive an application for that vaccine.
Yes, so we've had applications obviously from Pfizer, AstraZeneca and Janssen. The Janssen one is the next most advanced, and I asked for Chris James, the head of MedSafe, just for an update on that. They've got information coming in on a rolling basis, and they are planning to convene the committee that reviews all of that information in mid-April, and then we'll act on their recommendation after that. AstraZeneca is on a slightly slower time frame, but the Novavax vaccine is, again, it's just further behind in terms of the clinical trials, so we haven't yet had a formal application, but we're in discussion with the New Zealand agent of the manufacturers.
Do you have a tagline? Do you have a tagline for the campaign? Unite for the vaccine or the like?
That's been worked on by people who are brilliant in this regard, not me. But I'm very simple on this. I just encourage people to go and get good information and really strongly encourage people to be vaccinated. This is a safe and effective vaccine. Thanks very much.
Thank you.